Good day, everyone. Today I shall be talking on periocular rejuvenation with dermal fillers. My name is Debraj Shome, and we run a chain of clinics called the Aesthetic Clinics, which are present in multiple cities all over India. Certain financial disclosures are necessary. I've been a key opinion leader with Allergan and MERS, which make the fillers that are used in this presentation, as well as Aptos, which are the threads which are used in this presentation. Acknowledgement also to the Aesthetic Clinics Dermatology team, which is led by Dr. Rinki Kapoor, which the team makes the skin look better, and therefore all our results look better. The eyes say it all. If you look at this Bollywood superstar, it's obvious that the rest of his face has remained almost the same, but the eyes say it all. And because socially we are programmed as social creatures to look into the eyes while talking, any under-eye aging leads to a disproportionate impact on the rest of the face. So therefore, under-eye rejuvenation is very, very important for holistic facial rejuvenation. We all understand that the OG curve is a sign of youth and beauty. This is typically seen in young women, especially when you look at them at a 45 degrees angle. It consists of an under-eye trough, the prominence of the malar area, another hollow below that, and then the mandibular prominence. Faces look good when they have curves, and our job as surgeons is to recreate those curves wherever they have gone down. The symmetry of the eyes is incredibly important. If you looked at this beautiful lady, you would turn around and look at the symmetry of the eyes as well as the brow area, and you would think that she's extremely beautiful. In fact, you've been concentrating on the eyes so carefully that you've missed the fact that the left side of her lip is actually very asymmetrical. It's clearly a poorly done filler job. But because we are concentrating on the eyes, it can hide a lot on the face, and that's the important part of the eyes, and that's how it's important to take care of the eyes almost as the first port of call in any facial rejuvenation. Basically, facial aging is the glide plane of the face sinking down, mother gravity being ever so kind, and pulling all the facial tissues downwards and medially. If we understand this basic fact that all facial aging is downwards and medial, we also understand that all anti-aging procedures have to shift the facial tissues upwards and laterally, which means that they need to be shifted up, whether we use surgery, whether we use fillers, we use threads, or we use any other medical devices. Now, obviously, because the under eye area is also the thinnest skin of the human body, it shows the earliest signs of ill health, stress, and aging. Dermatologists tend to think that fillers will solve all. Plastic surgeons are have the same problems. They tend to think that blepharoplasty is a similar sort of a panacea. But actually, the truth is, you'll need to have different tools in your toolbox. And it's only through a systematic diagnostic approach and individualized treatment that you can treat the eyes in a manner which is holistic, in a manner which is long lasting. Now, if this patient was shown to you and you were asked whether this is a medical or a surgical case or both, most of us would turn around and say it needs a transconjunctival blepharoplasty, which is performed for the lower eyelid to sort of alleviate the eyelid fat bags. But the truth of the matter is that the texture, tone, blemishes, scars, and the quality of skin cannot be improved with surgery alone. And that's where a combination therapy using lasers, using medical devices, using fillers comes in. What we do is, whenever we describe under-eye rejuvenation, we tend to use a morphological approach. People and students and young trainees generally tend to find it easier when we talk in terms of troughs, tunnels, valleys, and mountains, compare them to the under-eye problems, and showcase how to diagnose the problems and treat them depending on the problems and the patient requirements. For instance, the tear trough deformity are the troughs, and that's caused by the tear trough ligament, which attaches to the medial side of the lower eyelid and causes the trough that we see. Then we have the tunnels, which are created by the hypertrophic orbicularis oculi muscle. Then we have the valleys, and we have the mountains as well, which are the displaced under-eye fat bags. Understanding the etiopathogenesis of each one of these and then suggesting the treatment, putting in mind the financial situation of the patient, the financial planning, the age of the patient, the desires of the patient is the appropriate way to really go ahead and reach a conclusion on the best procedure for our patient. This is a paper of ours which was published in the Journal of Cosmetic Dermatology in 2023, and it's an innovative approach using a higher G prime filler, which is used to correct the tear trough deformity. We should remember that traditionally we've been advised that whenever there's a tear trough deformity, the first thing to do is to go ahead and stick a needle there with a low G prime filler and just fill the trough. But the challenge with that approach is the low G prime filler A does not last very long. Most of the low G prime fillers last less than a year in situ, so which means that the patient has to come back pretty often for a repeat injection. And the second problem of that is that the low G prime filler itself, I mean, when you go in and inject medially, you will cause some amount of bruising. That's a more dangerous area. Trainees find it, or younger surgeons find it very difficult to apply or inject it properly. And if you inject it superficially in the medial part of the under eye area, it leads to what is called a bluish discoloration or a Tyndall effect, and can look very unesthetic because it can lead to development of a convex lower eyelid. And as we saw on the OG curve, it's usually a concave lower eyelid which looks more aesthetic. This particular paper spoke about and divided the classes of the under eye deformity or the under eye volume loss. We have to understand that this volume is being lost because it's shifting downwards because of the downwards and the medial movement of the facial tissues. And it's divided into class 1, class 2, and class 3, depending on whether the under eye hollow is only medial or extends right up to the lateral orbital rim. Instead of going ahead and injecting the typical traditional way, we inject the fillers laterally, as you can see in our patient, as opposed to the image, the AI generated image, which shows the traditional method of injection. But in our patient, you can see our injection points are with a high G prime filler, and this high G prime filler is then injected inferiorly and inferolaterally. What happens is when you inject there a bolus dose, you're injecting basically below the orbicularis oculi muscle. This causes a tightening of the orbicularis oculi muscle because you're injecting supraperiosteally, and the tightening of the orbicularis oculi muscle through a process called myomodulation leads to the inferior and the medial part of the eyelid and the tear trough becoming better, even though you may not necessarily directly inject the medial part. The first thing that we do whenever we are injecting under eye fillers is to inject the cheek G point. The cheek G point is on the malar area, and it's a very important point because by raising this, you can actually cause, by injecting the zygomatic arch and injecting the malar area close to the zygomatic arch or the larger G point, it is important to raise the cheek. You understand and you can see it on yourself every time that you raise the cheek, you actually are able to cause the under eyes to look much better even without doing anything to the under eyes. The under eye hollow primarily occurs because of malar fat pad descent, and by raising the cheek, we automatically make the under eye hollows appear better. The high G prime filler has a cheek lifting purpose in this sense. This is how the fillers are injected in the cheek G point. Again, anterolateral. Again. We haven't gone medial, but look at his eye. Look straight.
You did one more point?
Yeah, just here. Come here. So once you do that, you can see that the cheek appears raised. And because the cheek appears raised, even on this patient, you can see the medial part of the under eyelid starts to look better immediately because of the tightening of the muscles and the myomodulation that I just described. Again, anterior. After that, we start injecting laterally on the orbital rim. These are supraperiosteal injections, which again are injected below the orbicularis oculi muscle. When you're injecting laterally on the orbital rim, there are no blood vessels there, and therefore the bruising is much less, and the risk for getting into a vascular complication is far lesser. The myomodulation, or the mechanism of change of the pull of the orbicularis oculi muscle, causes the tightening of the orbicularis oculi muscle as a hammock, which in turn improves the medial tear trough even without the need of medial injections. Since this lateral part is a relative avascular zone, it's safer and causes less bruising. You can see how we are injecting laterally, and there you don't even need to aspirate because literally there are no blood vessels there. You inject a bolus dose, you're injecting directly on the bone, which is supraperiosteally, and once you've done that, you flatten the bolus out immediately, and doing that itself makes the muscle stretch. You're below the orbicularis oculi, just above the bone, and by doing that, you're causing the muscles to become tighter, and the muscles becoming tighter makes the medial part of the tear trough look better, even though you're not injecting medially. Now, this is what happens with the high G prime filler, and by using this high G prime filler, the results will also last longer, the risks are lesser, and it's easier to teach younger surgeons and trainees. Your chances of the Tyndall effect are also much lesser. So that's what we do. So you start with lateral and then go inferolateral, where the lateral orbital wall and the inferior orbital wall sort of come to a joint, or where they tend to merge. So we are going inferolateral now. Now, we also have to inject on the inferior orbital rim. In the inferior orbital rim, we understand that's the infraorbital foramen. The infraorbital foramen is a very fixed foramen. When cadaver studies, it has been shown that it lies anywhere between 8 to 12 millimeters from the inferior orbital ridge. So what we can do is we can inject directly on the inferior orbital ridge, in which case you are above the infraorbital foramen, and it's a very safe zone because there's a fixed foramen. And so if you inject it carefully, you can actually cause a lifting in the inferior part of the eyelid. This is important in a number of patients because of the foramen here and the exit of the infraorbital vessels as well as the nerve. What can happen is the under eye skin can be tethered to this foramen, and that causes the depression to appear pronounced. So injecting on the inferior orbital ridge in the midpupillary line above the infraorbital foramen avoids any vascular complication and makes the skin come up, thereby reducing the depth of the tear trough issue which we have. You can see how this injection is done. You can see that the patient is looking straight ahead. We are on the inferior orbital ridge. If you're just starting out, you can even use your finger to protect yourself from getting into the orbit, and you inject straight. Sometimes there's even not even any need to aspirate because you are just on the bone. You know your anatomy. There is no blood vessel there. You're staying exactly on the ridge, and by doing that, you're able to go ahead and make sure that you are injecting just below or around the infraorbital foramen. That's why you can go ahead and cause significant changes in the way the infraorbital area looks. If required, this should have solved your under eye tear trough problem or the tear trough deformity in almost 85-90% of your patients. However, there might be some patients in whom there is still a little bit, especially older patients, in whom there might still be a little vestige of the tear trough which is present medially. In such cases, if required, as a last step, we could do a deep medial injection. In this also we use a high G prime filler, but our suggestion is if you do not have as much experience and you're just starting out, use a low G prime filler for this particular area. So you might need two fillers, one high G prime filler for the lateral part, one low G prime filler for the medial part, or a Juvederm voluma for the lateral part, a Juvederm volbella for the medial part. We use a high G prime filler because the effects of this filler last long. If you are confident of your technique, you can go deep with the needle bevel down so that the filler is deposited supraperiosteally, and this avoids a Tyndall effect. So this is how this medial injection is performed.
Don't move.
So your needle should be so deep that you're not able to see the tip of the needle at all. That shows that you're on the bone, you're supraperiosteal, and actually you're below the tear trough ligament. That is important. Also, trying to move the needle will not allow the needle to move freely if you're in the right plane, because the tear trough ligament is a deeply adherent to the medial orbital wall and the medial part of the orbit. And so as a result of which, you will know you're in the right plane immediately. Now, using these techniques, you can set a lot of things right. If you look at this 28-year-old model coordinator, she came in because she had these tear troughs. There is also the appearance of a small eyelid bag which is appearing. Using these techniques, 2 weeks later after the injections, you can see how the lid cheek junction has become shortened, the eyes appear much more radiant, and she appears much more younger and rejuvenated. Similarly, for this 29-year-old, same sort of tear trough issue, and we go ahead and rejuvenate it. Again, you see how the lid cheek junction has shortened. The patient looks much more aesthetic, much more rejuvenated, much more rested, and less tired, if you will. Some of our patients also have a hypertrophic orbicularis oculi, which means when they smile, the eyes become really, really small. In these patients, doing a little bit of botulinum toxin to open up the eyes with fillers in the tear trough area leads to a nice combination results and leads to leads to the under eye area becoming far more aesthetic. One of our patients came in with the fact that there was some orbital dystopia. She came in because she thought she needed ptosis surgery, but if you look carefully, you can see that the pupillary reflex or the light reflex is right in the center of the cornea. So clearly, there is the MRD1, which is the upper eyelid area, is in the same area. But however, you can still see that there is some amount of difference between the right and the left sides. That is more because the right eyebrow is higher than the left eyebrow. Also, you can see very clearly below the cornea on the right side, there's an inferior scleral show, which is not there on the left side. These changes get even more magnified when the person tries to smile, and you can see the hypertrophic or the bunching up of the orbicularis oculi muscle causes the left eye to look significantly smaller than the right eye. However, the problem is in the difference in the orbital shapes, and therefore going ahead and performing a ptosis surgery is of no consequence. It's actually addressing the wrong problem. So therefore, what we did was do a little bit of botulinum toxin in the lower eyelid area, do a little bit of fillers in the tear trough, and that's the sort of result you can create. So essentially, Botox, a little bit of fillers, and then you can take the patient there, which is a significant difference from the way the patient initially looked. And in fact, when you look carefully, you can see that the smiling face has now changed completely. The botulinum toxin will last only 3 months, but it only costs a very few dollars to get this done because it needs hardly 2 units per eyelid. But the fillers will last for about 18 months or so. This patient has been really happy with the results. She does face the camera, the high definition camera, on a regular basis, and she's happy to get this treatment done regularly, which is almost every 18 months or so, in order to maintain the results. We also have patients who have, again, a little bit of an asymmetry on the left side compared to the right side. The left side appears to be raised, the eyebrow is higher. There's also a greater tear trough deformity as well as under eye fat bags on the left side as compared to the right side. In these patients, making sure that we use fillers may be a good idea. A, because the patient here is very young, she's 32, she's not interested in blepharoplasty surgery. And B, even if you try to do a blepharoplasty, the right eye appears to be reasonably okay. So why would you do a one-sided blepharoplasty? So therefore, we went ahead and did some fillers, immediately past the fillers, post the injection point. You can see how much of a difference it makes. And the moment you do that, you can see that the patient's entire face actually looks more symmetrical. You've not touched the rest of the face, yet the face looks symmetrical. And the reason for that, obviously, is because the under eyes play such a disproportionate role in facial symmetry. This is 1 week later, and you can see how the lid cheek junction has got shortened, how she looks much more aesthetic, balanced, etc., because of the under eyes being treated with fillers. Temple injections are also important. Temple injections are done for eyebrow lifting, especially in the patients like the earlier patient, where there's an asymmetry. We can do temple injections for eyebrow lifting. You can perform the temple injections as deep supraperiosteal injections, and because you're injecting deep to the temporalis muscle on the temporal bone, you're able to cause myomodulation of the temporalis muscle, which in turn causes brow lifting. Sometimes you can get even 2 to 4 millimeters of brow elevation, especially when you combine it with botulinum toxin in the central axis to the corrugators and the procerus. This procedure can be used for brow symmetrization. Most importantly, the periocular region then looks more relaxed, especially in patients with increased brow fullness, and this can result in very aesthetic results in women especially, who with age have a fuller brow and may not be able to apply their eyeshadow on the pretarsal area. So greater pretarsal visibility is something which happens with this temple injections. You can see how the marks are made. This is made, I already explained how the anatomy is defined. So you avoid the superficial temporal artery, go straight on the bone, aspirate, and then inject directly 2 points, which causes the myomodulation on the temples. Now, moving on to the subbrow injection. The sub-brow injections can improve the brow prominence, especially when combined with the temple injections, can cause the eyes to appear more rested and awake. And the greater pre-tarsal show from a combination of these injections is a boon for older women. There are also forehead injections which we perform regularly. The combination of the temples, the sub-brow, and the forehead injections with high G prime filler ends up making the transition zones far better. I will demonstrate that in the video the next. And this also removes the static forehead lines in the forehead area. This can be an adjunct to the botulinum toxin injections, but just the botulinum toxin will not help in static forehead lines. So this is a nice combination to do. We do this injection with a cannula. The injection is deep to the frontal aponeurosis supraperiosteally in the forehead glide plane. So that's the sub-brow injection being done, and the forehead injection being done. And you can see that with the forehead injections being done, you can actually glide easily with the cannula and make the static lines better, and also improve the transition zone between the temples as well as the brow with the brow injections that you've done. The same entry can also be used for the sub-brow injections. There are also lots of other adjuncts we use, including facial thread lifts, etc. And the combination of thread lifts and lasers can make our under eye area and the periocular area look far more relaxed. Our workhorse lasers are the fractional CO2 laser, which is used for eyelid rejuvenation, and the Q-switched Nd:YAG laser, which is used for reducing pigmentation in the periocular area. So what we do is, if there is a dark under eye area, we first do the fillers with the hope that the fillers will go ahead and stretch the skin and make the under eye area look better. And then once the hollow has been addressed, if some residual pigmentation remains, which is dermal pigmentation, we treat it with either skin peels or do a Q-switched Nd:YAG laser to reduce the pigmentation and make the under eye area look even more aesthetic. All in all, a beautiful eyes resemble a beautiful face. The under eye area can be the first sign of aging, is a very tough area to treat. And making sure that we don't get stuck in our heads, have a wide armamentarium of treatments available, and use them in the appropriate patient, all this ensures that we have the best possible results, and we can go ahead and change faces and eyes the way we are supposed to. These are some of our training programs. This is, of course, a much more dated training program from 2022, but this tends to occur every month at our centers or our corporate headquarters in Mumbai. And if you want to learn some of these techniques in better detail, you can attend some of our programs, including our long-term fellowship in facial plastic and cosmetic surgery and our short-term fellowships in facial aesthetics, etc. And all in all, I once again thank you all for your kind attention and a patient hearing. If there are any questions, etc., here's my email. Please do reach out, and we look forward to you analyzing and treating your patients better, and hopefully our experience garnered over the past 15 years will be of use to you all. Thank you once again to you all, and see you soon.